Good evening, sir.
Good evening. All set?
All set, sir. So, sir, this is the last module today we are going to conduct,
Yes.
sir. And it is getting held in entire South Zone, including AP, Telangana, Bangalore, and Kerala.
You can hear us? Okay, let me just see.
So, still 4 minutes remaining. We'll start sharp at 5.
Sure. If you should get connected.
I think we are live, sir. We can start now.
Okay. Thank you.
So, warm good evening to all the respected doctors and our colleagues. At the outset, on behalf of Mankind Pharma Limited, I, Dev Kantyagi, welcome you all for the last module of NDAC Advanced course. And the title of today's module is Dyslipidemia and Hypertension in Diabetes. And we have with us our esteemed faculty, Dr. Prasanna Kumar sir, to take us through on the same. So, I would request Dr. Prasanna sir to start with the scientific proceedings.
Good evening, everybody. Thank you, Dayagi. Let me share my screen. Can you see the screen now?
Yes, sir, it is visible. Yeah.
This is the last module among the 6 modules that we have discussed. Today's module will be dyslipidemia and hypertension in diabetes. This is my conflict of interest. And this is my disclaimer. Now, what are we going to learn in this objective model? First, metabolic syndrome. What is metabolic syndrome? We have been hearing for more than 2 to 3 decades. Hypertension and diabetes, clinical manifestations, screening, and how to manage hypertension. Then, very important, dyslipidemia. What are the features of diabetic dyslipidemia? And what is the relationship between diabetic dyslipidemia and coronary vessel diseases? Then, statins, when to use, how to use, anti-platelet agents, and combination therapy in diabetic dyslipidemia. All of you know that metabolic syndrome is a very important thing. It's a combination of obesity, hypertension, dyslipidemia, and it also involves the impaired glucose tolerance or diabetes as such. So in hypertension, we are going to discuss how to treat hypertension, particularly in diabetes, and what is the difference between intensive and standard control of hypertension. What are the statins? What is the combination therapy? How do you see combination therapy, especially when you have dyslipidemia, which is combined dyslipidemia of hypertriglyceridemia and hyperlipidemia? And about platelet therapy, what are the available medicines that we have got? As we already said, metabolic syndrome is a syndrome complex of comprising of insulin resistance, obesity, and dyslipidemia. Ultimately, this metabolic syndrome leads to increased risk of coronary artery disease or atherosclerosis. The insulin resistance, as you see, is because of the insulin resistance in the muscle, in the liver, and the fat. More fat a person is, then there is more increased insulin resistance. And in obese persons, then because of this metabolic syndrome, there are increased non-esterified fatty acids, inflammatory cytokines, and PI1, leptin, resistin, and adiponectin. As you know, when the obesity is there, there's increased leptin, there's increased resistin, and it is inversely proportional to the adiponectin. As the obesity increases, adiponectin decreases. Because of the liver insulin resistance, you get dyslipidemia. The diabetic dyslipidemia is especially increased triglyceride, increased VLDL, and the most important is increased more dense LDL, which is responsible for atherosclerosis and reduced HDL. This is the typical dyslipidemia in diabetes, and Indians as such, even non-diabetics have high triglyceride and low HDL, which is hereditary, as well as related to food habits like high carbohydrate rate. All these things is also associated with blood pressure and the increased blood glucose, impaired glucose tolerance, and diabetes. This is how the syndrome complex of metabolic syndrome has obesity, insulin resistance, diabetes, hypertension, and dyslipidemia. Ultimately, this leads to atherosclerosis and coronary artery calcification. You know, these days you have got the cardiac coronary artery calcification score as such. You can have the scoring by CT of that, and this leads to ischemic heart disease. Now, as I said, the Asians as such have a peculiar phenotype. What are they? We have got a high waist-hip ratio, then relatively low waist circumference as such, low value BMI, though we look thin, but actually we have more fat. That is why the BMI of Asians and particularly Indians has been different from the Caucasians. For the Caucasian normal BMI is 25, but Indians, both men and women, it is 23. So between 23 and 25, it is overweight, and 25 is already obesity as such. And we have less lean mass, as you can see, muscle mass, basically genetically we have less. And because of this low value of BMI, high waist-hip ratio, and lean body mass, we have higher percentage of body fat at a given time. And you have seen this YY syndrome where Yagnik has compared with his friend in the Europe. And though Yagnik says, I look thin, I have got more fat compared to an European, he's much higher weight and looks obese as such. And this is true even from birth also. When they check the fat content of children in Singapore, where you get Singapore children Chinese, and they have got Singapore children who are of Malaysian origin as well as Indian. This is one country and proud where you can see all the three. Even at birth, Indians have higher fat compared to Malaysian, compared to Chinese infants as such. So what is the relation between diabetes and cardiovascular disease? Diabetes and elevated glucose linked with approximately doubling of cardiovascular disease. Hypertension, diabetes, dyslipidemia are significant risk factors for cardiovascular and cerebrovascular disease. And cardiovascular disease risk in individuals with diabetes can be reduced by lowering blood pressure, optimizing glucose level, and using lipid-lowering medication. That is why in this module, we are going to discuss how to manage hypertension and dyslipidemia, because in the past 5 modules, you spoke enough about the diabetes and how to manage. Now, the question is, the hypertension is very common among individuals with diabetes. Almost 30-40% of them have hypertension, and prevalence depends upon type and duration of diabetes as such, age, sex. As age advances, hypertension more. Men have more hypertension, women. Race and ethnicity. Nearly, even forget diabetes, non-diabetics in India, if we say above the age of 40, nearly 28 to 30% of persons above 40 in India have hypertension. We have seen even in rural areas, about 28 to 30% as such. BMI, higher the BMI, more hypertension. History of glycemic control, presence of kidney disease. With the onset of kidney disease, whether it is glomerular nephritis, interstitial nephritis, diabetic kidney disease, the blood pressure increases. Strong risk factors for atherosclerotic cardiovascular disease, heart failure, and microvascular complications are common here. Now, the definition of hypertension has been changing. It is supposed to be 150/90, then became 40/90. So sustained hypertension equal to more than 140/90 is common among patients with type 2 diabetes. Previously, they said you don't have to treat systolic hypertension. 30 years back said, no, you have to treat above anything above 140, you should treat. Then they said normal pressure is enough. No, now the European Heart Society and European Society of Cardiology defines normal blood pressure is 120 by 80. If that is true, why not reach that? I'm not happy reaching 140/90. If we can achieve 120 by 80 without complication, with or without medication in all your diabetics, that is better than in 140/90. Because epidemiological studies have shown even 2 millimeters systolic increase can lead to more complication. So this is the one where it shows diabetes and hypertension with overlapping problems globally. You see diabetes is 285 millions and by 2034, 39 million. If you look at hypertension globally, 972 million, nearly 3 times more, and by 2030, 1.56 billion. That means hypertension is almost 3 times more prevalent than diabetes. And when you have both 40 to 80% of diabetics, as I told you, as hypertension, depending upon the age, ethnicity, when you look for it, minimum 40 goes up to 80%. Diabetics have 2 times likely to develop hypertension. Because of this double trouble, it leads to peripheral vascular disease, where in diabetes risk increases 2 to 4 times, increased risk and proportion of severity of blood pressure, and 2 times more chance of the stroke as such, and 3 times more likely to have coronary heart disease, 2 times likely to have left ventricular hypertrophy, 3 times more likely to develop congestive heart failure. So also, when you have both hypertension and diabetes, 70% more end-stage renal disease in USA due to diabetes or hypertension, and increased risk for retinopathy. Most often when you see patients with diabetes who develop retinopathy, especially when they have both diabetes and hypertension. That is why this double trouble, we have to manage both very well. So now there are many types of blood pressure. One is isolated systolic hypertension. Diastolic normal may be 80, 85, but systolic 142, 150, 160, 180, 200. And less reduction in nocturnal BP. Usually there is known as nocturnal dip. It should occur when you go to bed. If it's lost, it is got the first thing that is loss of nocturnal dip of hypertension. Higher baseline heart rate. If your baseline heart rate is 80, it is better, 75 better compared to 90 and 100. Some people always have, because when there is no diastole, no relaxation, people with a higher heart rate are likely to have more problem. If you see athletes who are exercising regularly, the heart rate may be 70, 80, even when they are exercising, never reaches 120, 130, because over a period of time, conditioning of heart. Enhanced variability in people. Just we talk about glycemic variability few maybe modules back, because we can make out by ambulatory glucose pressure. So variability in BP is also bad as such. For that, you have got ambulatory blood pressure measurement, which can detect. So you can have home blood pressure monitoring, office blood pressure monitoring. You can have even ambulatory blood pressure monitoring and decide when it is going up, when it is coming down 24 hours, and is there nocturnal dip or not. How to screen and diagnose hypertension? Blood pressure should be measured at every routine clinical visit. Whether patient comes to you every month, 2 months, 3 months, or first time, you must measure blood pressure. Those with elevated blood pressure should have it confirmed using multiple reading. Don't say one blood pressure today, 150, 92, I will start medication. Have multiple readings over 3 to 4 weeks. Consistently, when it is high, then you can take it. Or within a day itself, you can have 24-hour ambulatory blood pressure and look at that. You'll say what percentage of blood pressure is higher. Show it to the patient. See, your blood pressure is higher when you're walking, when you're working. So we should start it. All hypertensive patients with diabetes should monitor their blood pressure at home. So today, when a patient has diabetes, we ask them to buy one glucose meter to check blood sugar regularly, daily, weekly, whatever it is. Ask them to buy blood pressure manometer. That is sphygmomanometer, glucose meter. Ask them to buy oximeter, because these days with corona, check your oxygen level regularly. Ask them to buy weighing machine, because in case they have any increase or decrease in weight, every week they should check their weight. Last but not least is thermometer to check their blood pressure whenever they feel they are feverish. So these are the 5 meters which are important: glucose meter, sphygmomanometer, thermometer, oximeter, and weighing machine, which is very accurate or even digital. So it's very important how you blood pressure. This is the position. Patient should be sitting comfortably 5 minutes before you measure. Sit in a chair with both feet flat on the ground. Place your arm at the level of your heart like this. Stay still and do not talk as the blood pressure machine operates. Nowadays, we get blood pressures where there are automated blood pressure approved by FDA. Any patient walks in, puts his hand there, automatically it will measure blood pressure. You don't need a person to do it. Then you have got BP apparatus, which will measure 3 times blood pressure over a period of 3 minutes automatically, and it will give a final reading, which is the average of the 3. So measure your pressure in the morning, right after you wake up, or in the evening before you go to bed. If you get up 6 o'clock, before 7, you check. If you go to bed 10 o'clock, 9:30, 9:45. Why? If you look at it, most of these strokes, heart attack occur early morning. Typical history is patient gets up at 5 o'clock, goes to the toilet, he strains, he falls down, he would have had a stroke. That is why measuring blood pressure within 1 hour after getting up, because that is the time activity occurs, the blood pressure shoots up. It may be less in the afternoon. Try to measure your blood pressure at the same of every day. Suppose you are in the habit of waking at 6, every day between 6 to 7, measure the blood pressure. These are the instructions you should give it to your patient. There is an enhanced variability in blood pressure in individual diabetes because they are prone to develop orthostatic hypertension. So when the patient comes to your clinic, ask him to sit down 5 minutes or lie down, check blood pressure. Ask him to stand 3 minutes, check blood pressure. If the difference is more than 40 millimeter drop in the systolic, that is orthostatic hypotension, and you have to change the medicine or take measure. Hypertension is more resistant to treatment in diabetes. The response to treatment is poor in case of diabetics with hypertension. This is the reason why in this module, we are talking about the blood pressure, how to measure, when to treat, how to treat, what should be the target end. In a patient with diabetes and hypertension, and in a patient who is higher cardiovascular risk or lower cardiovascular risk, or a patient who is pregnant or non-pregnant, this is how it varies. In a diabetes hypertension, as I told you, to diagnose hypertension equivalent to more than 140/90 blood pressure, but target should be less than 130/80. That is what is the target, not 140/90, not even 135/85. When the patient is at lower risk, then it is 140/90. Patient with a higher risk, 130/80, lower risk, 140/90. In pregnancy who have pre-existing hypertension, it is still better to have 130 to 135. That is the mean blood pressure, which should be your target. Now, non-pharmacological, when they see the 2 or 3 occasion, the systolic blood pressure is 140 above, diastolic more than 90, and 2-3 occasion over a period of time, then you start non-pharmacological therapy. If they are overweight, ask them to lose weight and try to achieve ideal body weight. Most important, ask them to take low sodium diet. Most of these diets contain anywhere between 15 to 30 grams of sodium. Ask them to restrict sodium intake to less than 10 grams per day. If they are not doing, ask them to do exercise at least 30 minutes per day, 5 days a week, 150 minutes per week. And this is how the algorithm, when the initial BP is more than 140/90 or less than 160/100, then what you do, start one agent, look for albuminuria, coronary artery disease, and if you see that there is nothing, the best drug is ACE inhibitor, ARB, CCB, diuretic. If they have albuminuria, ACE inhibitor or ARBs are the first drug of choice. Of course, the lifestyle modification is the initial one, but when it is so high, better you start medication. Suppose the blood pressure initially is 160 and 100 and above, then you start lifestyle modification, start 2 drugs, even 1 drug is not sufficient. And if they have albuminuria, then you start ACE inhibitor, ARB plus CCB or diuretic. If not, you can start any of the 2 of the 3 options, that is ACE or ARB, CCB and diuretic. Please remember, ACE inhibitor or ARBs and CCB and diuretic, these are the 3 drugs. You can choose 1 or 2 or 3 for hypertension, the first 3 line of drugs. Then assess the control. In case treatment tolerated, target achieved, continue. If not meeting the target, then from 1 drug go to 2 drug to 3 drug as such. If they have adverse effect, change to alternative drugs which are available. Then if assess the BP regularly, and if still the target is not achieved, then you can go to other drug, consider addition mineralocorticoid receptor antagonist, or refer to the cardiologist. So many times we see spironolactone and others are introduced in such, that is the fourth drug. So many times, most of the diabetic between 5 to 10 years need at least 3 drugs. Some of them need 4 drugs. This is the algorithm by American Diabetic Association for patients who are diabetic and hypertension as such. So start with ACE or ERB because they are diabetic, then diuretic and calcium channel blockers are your second and third drug of choice. Now, what is the evidence for it? Clinical trials have demonstrated that treatment of hypertension to blood pressure to less than 140/90 reduces cardiovascular event, reduces microvascular complication as such, and intensive versus standard blood control. There are many studies like ACCORD BP trial, advanced blood pressure trial, heart trial, sprint trial. All these things, there were different populations varying from the 4,733 patients to heart trial, 18,790 patients, including 1,500 diabetics and age group between 40 to 75. And what did they see? In intensive one, target was less than 120. And systolic diastolic was what they achieved, 119/64. And some of them achieved even less than that. Diastolic blood pressure even less than 80. These are the target in intensive group. In the standard group, where it was a loose control, you can call them, they said 130 to 140 was the systolic, and then the diastolic they achieved 70, and there was a placebo control trial as such, and target blood pressure was less than 90 in the heart trial. So all these trials showed initially no benefit in primary endpoint, composite or non-fatal MI, non-fatal stroke CVD. Stroke risk reduced by 41% with intensive group, not sustained through follow-up beyond the period of active group. When they were in the trial, they could achieve, but it reduced the risk by 41%. Adverse events more common in intensive group, particularly elevated creatinine and electrolyte abnormality. Intervention reduced the risk of primary composite endpoint in them. 6-year observation follow-up found reduction in risk of death in intervention group. In the overall trial, there was no cardiovascular benefit with more intense target. In the subpopulation diabetes, intensive diastolic blood pressure target was associated with a significantly reduced, 51% reduced coronary vascular disease as such. This is how the various studies, the outcome of all these studies have been shown here. Definitely it shows in patients with hypertension, diabetes, reducing blood pressure to the target will reduce the risk of death by 27%, or even the primary endpoint as high as 60-70%. But when you try intensive care, there were some the problems in the electrolytes as well as in the creatinine as such. Next, we come to dyslipidemia. So you can individualize the target, but try to bring it below 130/80 if possible, most of the patient without side effect. Now, what is diabetic dyslipidemia? Whether it is elevated fasting and postprandial, triglyceride, low HDL, elevated LDL. Please remember, triglyceride should be measured in empty stomach or fasting, whereas HDL, LDL are not altered whether you do the blood sugar before and after breakfast also. Suppose somebody comes after breakfast, doesn't matter measure. After breakfast itself, a triglyceride is normal. You don't have to bother about fasting. Suppose it is high, next time ask him to come in empty stomach and check triglyceride. And the diabetic dyslipidemia is predominantly small dense LDL particle, which causes atherosclerosis. Lipid changes represent the major link between diabetes and increased cardiovascular risk in diabetic patients as such. Now, if you look at how dyslipidemia affects the heart, changes insulin sensitivity pathways in diabetic, increased concentration of free fatty acid, low-grade inflammation, and all these leads to overproduction and decreased catabolism of triglyceride, risk lipoproteins of intestinal hepatic origin. That's why when the triglyceride are high in diabetic, first thing is control diabetes before you reassess or treat the triglyceride. Next is, please look for secondary causes for dyslipidemia or hypertriglyceridemia. One of the common things is hypothyroidism. please ask every patient with a dyslipidemia to check thyroid function test before you start medication, because if it is associated with hypothyroidism, which may be asymptomatic, once you treat thyroid, it comes down. Once you treat the diabetes, triglyceride will come down. Now, this is what mechanism of the dyslipidemia leading to type 2 diabetic dyslipidemia, like lipoprotein, the clearance, as you can see, the hepatocytes, and then from adipocytes, triglyceride hydrolysis, free fatty acids is delivered to the hepatocytes, and these free fatty acids ultimately lead to increased beta oxidation, gluconeogenesis, or lipid storage, or increased triglyceride. As long as liver can handle the fat, does not matter whatever you eat, the triglyceride cholesterol will be normal. As age advances, liver becomes aged, then its capacity to handle free fatty acid comes down. That's why it leads to increase in VLDL and triglyceride acid. Now, what is the relationship between diabetic dyslipidemia and coronary vascular disease? Dyslipidemia increases the risk of coronary vascular disease in diabetics. Strong heart study, it shows 12% increase in CVD risk in diabetic subjects with every 10 milligram increase in the LDL cholesterol. Type 2 diabetes, there is a reduction in HDL cholesterol concentration that indicates increased risk of CVD. HDL function is severely impaired, that further increases the risk of coronary vascular disease. That is how this is the relationship between diabetic dyslipidemia, and these are the evidence to show that higher the triglyceride, higher the cholesterol, increased risk of CVD. Same thing. What is the relation? We showed you how diabetes, hypertension leads to more microvascular disease. So also LDL cholesterol high and leads to the dyslipidemia. And you can see here 31 signals for opposite effects on LDL and diabetes. And that also affects the liver metabolism. And thus it will have microvascular complication. So what is the treatment target? Primary target is LDL cholesterol. Don't worry about your first target is to see LDL cholesterol in a diabetic comes to below 100 as such, without additional CV risk. If the patient has CV risk, your LDL target is less than 70, not even 100. Secondary target is ApoB and non-HDL cholesterol. So recommended, not essential. Recommended target is 1 LDL below 100 without CV risk, below 70 with CV risk, triglyceride below 150, HDL more than 40, and more than HDL 50 in women. Of course, HDL is a non-modifiable risk factor. We see most often Indians with 30, 28, even 20, because right from birth HDL is fixed. Only thing that can increase HDL is exercise. No medication increases HDL. There were studies 20 years back where they said, okay, we cannot increase HDL by any drug. Let us give recombinant DNA HDL intravenous. When they give infusion of HDL, they did not see risk reduction, meaning HDL is a marker, is not a cause of the coronary artery disease. Changing the marker will not alter the progress at all. If you want to increase HDL, you will see it is only by exercise, nothing else as such. Sometimes I see somebody coming with a HDL 60, 70, 80, 100. Suddenly I look at him and, where are you from? He says, I'm an European, Danish, German. So these European race are very HDL, I have seen 100. I have yet to see any Indian more than 60 HDL when it is done properly. You should remember, lipid estimation is also very important. One, as I said first time, do fasting state, especially triglyceride. And you have to assess HDL. You have to assess HDL separately, what is known as direct HDL estimation. Most of the labs do total cholesterol, and then by mathematical calculation of triglyceride estimation, they calculate HDL. But direct HDL measurement is most accurate. So how to manage dyslipidemia? Comprehensive assessment of cardiovascular risk, moderate intensity, high intensity, depending on. That means if the cardiac risk is high risk, then treatment is different. If it is moderate risk, then it is different. First is lifestyle modification. As I told you, send them to dietitian, ask them to lose weight. Even 3% of weight reduction will reduce the cardiovascular risk by 5%. Today, Mediterranean diet or DASH diet is very, very important diet. Then reduction of saturated fat, trans fat. Increase the fiber intake of that natural fiber, vegetable fiber. Increase physical activity. These are simple lifestyle management of dyslipidemia and diabetes. Then reduce the atherosclerotic cardiovascular disease by weight loss, increase physical activity, medical nutrition therapy. And don't suggest, oh, whatever they are given diet chart for the, no. The medical nutrition therapy, MNT, is tailored to each patient, each type of diabetes, pharmacological treatment, lipid development, medical condition, glycemic control. So they have to see a nutritionist, and a individualized nutritional therapy is very important. If you don't have nutritionist, please refer to a qualified, competent nutritionist as such. Now, ongoing therapy monitoring with lipid profile in adults not on statins or other low lipid lowering therapy. Lipid profile is recommended at the time of diabetes diagnosis, initial medical evaluation every 5 years after that, under the age of 40 years. Lipid profile should be done. Whole lipid profile, don't ask just cholesterol. At the initiation of statins or other lipids, 4 to 12 weeks after initiation, or a change in dose annually. So when somebody is diagnosed diabetes, do lipid profile. If it is high, start treatment and monitor every 3 months till it is controlled. Once controlled, annually along with the kidney function test, blood counts, eye, foot, and cardiac assessment, you must check the full lipid profile in every diabetic under annual checkup. Now, how do we use, where do we use, when do we use statin, how much do we use? There are two types, what is known as primary prevention, secondary prevention. What do I mean by primary prevention? Here is a diabetic patient. He did not have any heart disease, no cardiovascular disease. What is secondary? He already had a heart attack, MI, or heart failure. We are starting therapy. Patient with diabetes, then 40 to 75 years primary prevention. Every diabetic between the age of 40 to 75 initiate statin without atherosclerotic cardiovascular disease also. And in such patients, moderate intensity therapy and lifestyle modification. Patient diabetes 20 to 39 with additional risk cardiovascular factors weakness, initiate statin therapy lifestyle. Patient between 50 to 70 are those with multiple atherosclerotic cardiovascular disease. You should use high intensity therapy. So moderate and high intensity therapy. 10 years of atherosclerotic heart disease, risk of 20% or higher, and estimate to maximally tolerated statin therapy. So this is the latest guidelines where depending upon the age of the patient, 20 to 40, 40 to 75, and patient with diabetes and patient with additional atherosclerotic cardiovascular risk, you decide are they the moderate risk or a high risk, and whether you should have only statins or add histamine along with that. Secondary prevention, that is patients already has heart disease. There you should use high intensity therapy, lifestyle therapy for patients of all ages with diabetes and atherosclerotic cardiovascular disease. Patient with very high risk using specific criteria, if LDL more than 70 on a maximally tolerated statin, another LDL therapy may be because that means 2 treatment for it. Continuous statins in adults with diabetes is 75 or RD on statin. Initiation statin therapy with diabetes age more than 75. Statin therapy is contraindicated in pregnancy. Please remember that. During pregnancy, don't use statin. Otherwise, if we see everybody above 40, irrespective of the risk, once they are diabetic, they should be on statin therapy. Then what do you mean by high intensity, moderate intensity? LDL, lowest LDL cholesterol by more than 50%, that is high statin. Atorvastatin 40 to 80, rosuvastatin 20 to 40. There were some guidelines which said, don't even bother to monitor that. Once the patient is diabetic, you start if they are in high risk, start 40 to 80 mg of atorvastatin or 20 to 40 rosuvastatin. There is nothing like a goal at all. If whatever the basic LDL, whether 100, 150, 200, by just giving this dose, if you can reduce LDL by 50% or more, that is the statin therapy reduced cardiovascular disease. What is moderate intensity? By moderate intensity means you can use the atorvastatin 10-20 That's what most of us use in all diabetics. Rosuva 5 to 10, simvastatin 20 to 40, pravastatin 40 to 10, lovastatin 40 mg, Fluvan pitavastatin you can use 40, 80 mg or 1 to 4, where you will see the LDL cholesterol by moderate intensity reduces 30 to 50%. So please remember, by using between the 10 to 20 atorvastatin or by 40 to 80 of atorvastatin, you reduce between 30 to 50 or more than 50% of baseline cholesterol. And by using 5 to 10 or 20 to 40 rosuvastatin, you can reduce 30% to 40% or more than 50% of the LDL. So you can choose your pair. In spite of using statin, if the LDL cholesterol doesn't reach the target, then you can use statins with estimate or statins in PKSK9 inhibitors, which is not yet available in India. You can also use statins and fibrate when there is a mixed dyslipidemia, and you will see, because the fenofibrate reduces the triglyceride, statin reduces LDL cholesterol more than the triglyceride. Of course, cardiologists are very happy using statin plus niacin, somehow because higher dose of niacin affects this blood sugar, we don't use much of that. Coming to the last thing, anti-platelets agent. Previously, they said every diabetic should be put on aspirin or anti-platelet therapy like clopidogrel. Now, aspirin therapy as a secondary prevention strategy, those with diabetes and history of atherosclerotic cardiovascular disease. Clopidogrel in those with documented aspirin allergy. So aspirin should be used in those who have got atherosclerotic heart disease or very high risk, not everybody. Clopidogrel is not the first choice. If patient cannot tolerate aspirin, then you can use clopidogrel. And cardiologists use dual anti-platelet therapy, low aspirin plus the P2Y12 inhibitor for a year after acute coronary syndrome. After 1 year, dual antiplatelet are not going to be much helpful. Long-term treatment with dual antiplatelet therapy, patient with prior coronary intervention, high ischemic risk, and low bleeding risk. Combination therapy of aspirin, low dose, rivaroxaban for patient with stable coronary and/or peripheral artery disease and low bleeding risk. This is where the cardiologists come into the picture, where if you have a very complex patient, refer to them, they'll be able to manage. Aspirin therapy as a primary prevention strategy in those with diabetes at increased risk of cardiovascular disease. If they are obese, if they have hypertension, and if they have dyslipidemia, if there's a family history of heart disease below 60, if you think patient is high risk, then only start them. To summarize my talk, hypertension and dyslipidemia are common conditions coexisting with type 2 diabetes as such. Then clear risk of atherosclerotic heart disease is very important. You have to identify and treat. Important to control the individual cardiovascular risk as such and preventing or slowing atherosclerotic cardiovascular diseases in people with diabetes. Large benefits are seen when multiple cardiovascular factors are addressed simultaneously. Then cardiovascular risk factors should be systematically assessed. Looking at patients, is he obese, overweight, or normal weight? Does he have hypertension or not? Does he have dyslipidemia or not? Again, very important, is he a smoker or not? Family history of premature coronary artery disease, father, mother, brother, sister, below the age of 60. Chronic kidney disease, they are all at high risk, because if we have diabetes, hypertension, chronic kidney disease, it is double trouble. Presence of albuminuria is a marker for future cardiovascular disease. Antihypertensive therapy reduces atherosclerotic cardiovascular events, heart failure, microvascular complication. Initial treatment may include ACE inhibitor, as I told you, or ARB, that is angiotensin receptor blockers, or diuretics, preferably thiazide-like diuretics, or dihydropyridine calcium channel blocker, are known as CCB. Now they have got single channel blocker, dual channel blockers. We have got so many advanced calcium channel blockers which have least side effect, very potent, do not cause partial hypertension like first generation, like amlodipine used to cause edema, partial hypertension. These things do not occur with the dual calcium channel blocker and latest calcium channel blocker. Multiple drug therapy may be needed to achieve blood pressure target. lifestyle intervention and glycemic control may beneficially modify the plasma lipid level as such. Statin therapy has been beneficial effects on atherosclerotic or cardiovascular disease outcomes in individuals with or without coronary heart diseases. Remember, in the last 3 decades, 4 decades, if there is one drug which has greatly reduced the cardiovascular risk, heart attack, it is statin. Don't believe what some of the people say, statins are not useful, they are dangerous, they cause diabetes. All these things are nonsense. Please use statins properly, whether it is moderate dose or high dose, in moderate intensity, high intensity, depending upon moderate risk or high risk, and it should prevent the cardiovascular disease more than 50% if you use either in primary prevention or secondary prevention. Statins are the drug of choice for LDL cholesterol and lowering cholesterol as such, and also they are the ones which give cardioprotection. Maximally tolerated dose recommended for those who cannot tolerate the intended initiation of statins. As I said, they have used anywhere between 5 milligrams to 40 milligrams of the statins as such, that is rosuvastatin, and 10 milligrams to 80 milligrams of atorvastatin. Recently, I saw one of my patients in the US, he was getting 100 milligrams of atorvastatin because some of the Westerners believe that their patient, they can go up to even 100, 120. In India, most of us do not go beyond 80 milligrams. But suboptimal treatment is very bad. Please use the proper, moderate, high intensity statin. Maximally tolerated dose recommended for those who cannot tolerate the intended intensity of therapy as such. Thank you for your attention. If there are any questions, I'll be happy to answer them.
Thank you so much, sir, for taking us through this part. Sir?
Yes.
Am I audible? Yes, 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 sir. So thank you so much, sir. So we have few of the question asked by our attendees. So first question we have from Dr. Manjunath, which is the safest antihypertensive drug in diabetes and role of multi-drug therapy in uncontrolled diabetes with HbA1c 10.5.
Very good. The first thing I said, because the general guidelines said you have 3 choices, ACE inhibitors, ARB, then you have got CCB calcium channel blocker, then they said diabetic. In a diabetic asset, first choice should be ACE or ARB. ACE inhibitors have shown all the data, if we see last 30 years, data is more with ACE inhibitor than ARBs. Please remember, never combine ACE inhibitors and ARB. If we combine the two, there is no advantage, whereas hyperkalemia will be worse, other side effects will be worse. So choose ACE or ARB. Sometimes patients with ACE develop cough, then we change over to ARB. Otherwise, both of them are safe, data shows ACE. The next thing is, if the patient do not reach the target, I told you target is 130/80 in most of my patients. If we can achieve 120/80 is still good. If they don't achieve it maximum ACE or ARB, my next choice is either I can add a diuretic and you can use hydrochlorothiazide, or you can use other diuretic. Indapamide is also very good because high dose of hydrochlorothiazide can cause hyperglycemia. That's why indapamide is the second one. Chlorthalidone, very long acting. Lot of patients use chlorthalidone rather than hydrochlorothiazide. So diabetics, it may be better to use chlorthalidone or indapamide, which will not affect your glycemia. So first choice is, second is diuretics, third is calcium channel block. If you look at it, diuretics and ACE inhibitors are not such a strong antihypertensive. If my patient has a very high blood pressure, though I start ACE inhibitor, I will add calcium channel blocker. They are very, very potent. Whether you take amlodipine 2.5, it crashes from there, but causes edema, partial hypertension. Now we have got cilnidipine, which is very smooth. You can start with 5 mg, go up to 10 mg, go even up to 20 to 40 milligrams. So calcium channel blocker, amlodipine, very potent, less side effects, or calcium channel blocker, cilnidipine. Now we have got azilsartan. So that is how we are getting newer calcium channel blocker. With these drugs of ACE or ARB, diuretic and calcium channel blocker, because when you use calcium channel blockers and diuretics, the edema and other problems are sorted out. So these are the three best. But still, there are patients where they are not. About a month back, he said, sir, I went to all doctors. Nobody can control my blood pressure. Always 180 by 100. I said, wait, you are on 3 drugs. You are on maximum drug. I'll give you one more drug. You start with that. Believe it or not, I started clonidine. Clonidine is a very old drug. 100 milligrams once a day, twice a day, thrice a day. When I used clonidine, within 3 weeks, his high blood pressure came to 130/80. He was so happy. This is the 4th drug I use. And it's a fantastic drug, I feel, in a resistant hypertension. What is resistant hypertension? Definition of resistant hypertensive, when the blood pressure is still more than 140/90 with 3 drugs, and one of them should be diuretic. This is the 3 drugs we said. ACE inhibitor, calcium channel blocker, diuretic. In spite of using 3 drugs, still the blood pressure more than 140/90, that is resistant hypertension. One drug which is very, very useful is clonidine, and used once, twice, thrice is fantastic. Remember one thing, never suddenly withdraw the clonidine, because sudden withdrawal can lead to rebound hypertension. You should be careful.
Right, sir. Thank you so much, sir. And the next question we have from Dr. Nagaraj. My serum lipids values are too low. I am diabetic since 32 years. Now hypertension. I am 71 years old.
Now, he said his lipids are low.
Lipid values are too low.
No.
Diabetic since 32 years.
Yeah, correct. But the question, what is low? Is LDL low, HDL low, or what is low is important. If your HDL is low, there is no medicine to increase your HDL at all. No drug will increase your HDL. That way, nothing can be done. If your LDL is low, you don't have to worry, right? Because if your HDL is low, you are prone for heart disease. That's what I told 28/30. If your LDL is low, there is nothing like medicine to increase LDL. And always one question is asked, what is the lowest LDL we can reach? There is no answer for it in medicine or science. One of the French lipidologists told me very clearly, when a person is born, what is LDL, what is HDL? The ratio between LDL and HDL is the most important thing. When you are born, ratio of your LDL and HDL is 1. If your HDL is 40, your LDL is 40. As you age from birth, 10 years, 20, 30, 40, 50, 60, your LDL increases, HDL remains same. So if you can bring down your LDL to even 40, there is nothing wrong. You don't have to do anything to increase your LDL. And I have seen patients with 20 LDL. So I don't believe, though there are some studies show very low LDL, there will be no cholesterol, you will not have any. The cholesterol, which is the base product to produce the hormone, don't believe all that. They're all theoretical. Lower LDL is better, but low HDL cannot be improved by anything. Even if you improve, it may not change. Only thing is exercise. We can marginally 2 or 4, you cannot increase 28 to 40. That's why some people said, you try everything, statin, blah, blah, everything. If your HDL does not increase, change the laboratory, it'll increase. If you go to a bad laboratory, your 28 becomes 60, you feel happy, but that is not.
Thank you so much, sir. Next question we have from Dr. Bhaskar. Some of the nutritionists are saying too much control of lipid levels increase the chances of Alzheimer, Parkinson's disease. What is your opinion, sir?
So there are studies that they say, but these are not, if you have to see, yes, no drug in this world is 100% safe, but you have to see risk-benefit ratio. What is the risk of not starting statin? What is the benefit of starting statin? Suppose, let us say 1,000 people take statin and you can prevent 30 heart attacks. 2 people develop side effects. Yes, just because 2 people have that, maybe little, these are all, you cannot have a randomized clinical trial to show that it is statin only causing Parkinsonism. By the time you get past on 60, 70, or so many diseases, or so many drugs, to say it's only statin out of these drugs which cause Parkinsonism is not correct. There is no definite evidence, but if you look at risk-benefit ratio, statin is the most important drug. Never believe such things. In spite of all these things, better take it because heart disease is more serious than Parkinson's. That is why I will not buy that. I will say, please put your patients on statin, discuss with them, ask them to read side effects. There are many people who see WhatsApp videos. No, doctor, I don't want to start statin. I've seen video telling naturopathy, this will control. Okay, sir, this is my opinion. You should be on statin. I'll prescribe the statin. Taking it is not your choice. You may give any prescription. Patient may not take antihypertensive, cholesterol diet. He may not take aspirin, and he may get into the problem. But as a doctor, it's your duty to write the best medicine, safest medicine, explain to the patient individually what is the importance, not to miss a drug. Patients may not follow 100% of your advice. It is left to them. Tomorrow, another person should not see, he has not prescribed statin. My father got attack. He did not prescribe aspirin. I'm going to sue him in court. You should be careful about the legal implication. Nobody else will come to the rescue when you have not prescribed the right medicine. They will always, you may take care of a patient 50 years. At 85, 90, patient gets heart attack. They will see who is the doctor treated. Let me find out what mistake he did, rather than trying to understand whether he followed the instruction or not.
Thank you so much, sir, for answering that query. And the last question we have from Dr. Jagdish. Is it necessary to advise statins to all the diabetics above the age of 50 years?
Thank you, Dr. Jagdish. I agree, not above 50, even 40 also. You should remember why. If a patient is diabetic, see, previously diabetes was a disease of 60s, 70s. Then it became 1 decade early 40s into. Today, I'm seeing a lot of patients between 25 to 30. Now, below the age of 30, you have to be careful because if you use statin, some of them can get into hepatic problems and others. Above the age of 40, every diabetic should get a statin. I told you how we should say 40 to 70. So, initiating statin between 40 to 75 for every diabetic, whether you use a small dose or large dose, 10, 20 minutes. This is one thing you see. Other thing is, if the risk is high, then you see moderate intensity and others. I practice at least start with 10 mg. If they tolerate, I go to 20 mg above the age of 40 years. But if they are moderate risk and high risk, I go from 20 to 40 milligrams or 48. There are a lot of debates whether statins for all or not. Now, to initiate the statin above the age of 75 who do not have risk, there is no data to show. Suppose he is 75 plus, recently detected diabetic, definitely you can start first time. But initiating a diabetic 20 years, already 75 years, doesn't have heart disease now. But even 75 or 80, whatever it is, if the patient has high cardiovascular disease, for secondary prevention, you can. So secondary prevention, there is no doubt, everybody should be on statin. The discussion is for primary prevention in diabetic, I follow above the age of 40, everybody should get a statin. Of course, moderate and high risk, irrespective of the age, even as early as 30, I will start statin. That's what I showed you earlier.
Right, sir. Thank you so much. And we have the last question coming from Dr. Karthik. Sir, which statin has the edge over other? Is it atorva or rosuvastatin? What are your take on this?
This is a very good question because a lot of people ask this. This debate is going on. Now, if you see always history, atorvastatin has a longer history compared to rosuvastatin. Rosuvastatin came because of residual risk over and above the atorvastatin, residual risk to bring down the. So if we see the number of studies, number of patients included, atorvastatin has stood the test of time longer. So atorvastatin is better than rosuvastatin if you take the history, number of patient trials. That does not mean you should always use atorvastatin because rosuvastatin, if you see, 10 milligrams of rosuvastatin is equal to 20 milligrams of atorvastatin. So that way, if we see for residual risk, and you see so many studies you have gone through that, so it is your choice. I will not say that one is better than the other. You can choose either atorvastatin, rosuvastatin, whatever you use. Some people use atorvastatin, they get cramps, they change over to rosuvastatin and say, sir, the side effects are lesser. So the choice is yours and patient. Cost of atorvastatin is much less compared to rosuvastatin. Discuss with the patient cost, side effect, benefits and all. Whether you use rosuva or atorvastatin does not matter. Some statin is better than no statin.
Thank you so much, sir, for answering all the queries. So as we move towards the completion of this NDEC Advanced module course, I propose word of thanks to each and every participants who have joined us in all the modules. Thank you, everyone. And special thanks to our esteemed guest, the faculty, Dr. Prasanna Kumar, sir, who has taken time out from his busy schedule and conducting all the modules very nicely. So thank you so much, sir. And thank you, everyone. We, Mankind, will be keep continuing such education initiatives in future also. Thank you, everyone. Thank you, sir.
I thank all the participants for having been with me throughout these 6 modules. It has been a very interesting journey. For the last 35 years, this is maybe 350 or 500 we have. But every 2 years, 5 years, you see, the module we prepared 30 years back, module we are doing today, totally different. This is not something new. But every time it is new for me. From 1990 to 2021, 31 years of journey. Hundreds of such modules have been. Is there a need? Yes. Even if all of us, 5,000 people do 100, still it is not an effect because every year there's a change in ADA, American Cardiac Association, European guidelines and change. New drugs will come, whether diabetes, hypertension, cholesterol. So thank you for being with us. And also it's a learning experience with me. Like today, the doctors like Jagdish and others have asked such good questions. It is your question which made us think. I hope that Mankind will continue not only for South India, North India, East and West, all over the country. This is only beginning. What I feel, I told them that this is the basic module. We should already, okay, sir, I've attended, good. 2022, what you should do? Okay, let us say we have 2 modules, which is advanced in diabetic. We have not covered everything. Right. There are still so many things, advanced module. Then people will say, good, all the knowledge, where is my driving license? What do you mean by driving license? I want to set up a diabetes clinic, how to set up a diabetes clinic, how to recruit people, how to train people, what machine I should have, what test I should have, how my diabetes clinic can be improved, what is known as clinical upgrading of skills, assessing that. So how do you say my clinic is better compared to last year? You don't have to compare with others. Like Arjuna, I said, who is your competitor? I'm my own competitor. I should be a better skillsman compared to yesterday. So how do you assess your clinical practice? Clinical practice improvement skills. And what are the new things? Sir, you didn't discuss about diabetes pump, how to use EGP, you did not discuss. I want to know more and more of digital technology, how to do telemedicine, teleconsultation, video consultation. So these are the things, if Mankind agrees, maybe 2022 develop digital solutions for diabetes distant management. How to have a diabetes clinic, how to set up a clinic, how to run it, how to evaluate, how to use pump, how to use all these technologies, continuous glucose monitoring, how to have non-invasive insulin this. We didn't discuss about nasal insulin, oral insulin. So these are some of the things I think in future we should have. And this is a continuous progress. Don't think that the diabetes modules we have done 6 is ultimate. And a person, as especially a doctor, learns till he probably stops practicing, we have to continue. I've been a student of diabetes endocrinology last 40 years. The learning will never stop. And we should also have more and more of discussion. Many times people said, I don't want to talk, we just have a discussion. We will ask you only questions on this, you answer, no PPT to kill. So like that, there are various ways, or we can say, we'll bring some cases, complicated cases. The participant will say, okay, they have sent 10 cases and we'll discuss 3 cases over 1 hour. Everybody has a right to say, I would treat like this, everybody is right. So there are many exciting ways of learning which are bidirectional, advanced courses, technology. So learning continues. It will never stop. Don't think this is the beginning of learning of diabetes. This is the minimum of diabetes. There is still so many things as we go along, next 5, 20, 30, 40, even 50 years. Somebody else will come and will come. Thank you for the opportunity given. I thank Mankind and Dev Tyagi and all of you who have made this successful, participants all over South India. Take care. Bye. Have a good evening.
Thank you so much, sir. As you rightly said, the learning will never stop. And definitely we will have the advanced diabetes course, as you mentioned, on the diabetes digital solutions under your guidance. We'll plan and come back soon. And it was a pleasure having you on board. Thank you so much, sir.